Welcome everyone to our webinar for evaluation and management modifiers that affect the global surgery concept. This webinar is not designed to talk about all E&M modifiers or even E&M modifiers at different times. What we're focusing on is it has to be during a global surgery period. If not, that's not information we're going to try to cover today. I will do the best I can to get you information at the end, but I just want everyone to be aware of that. My name is Tom Ryan. I'm with Provider Outreach and Education, and I'll be your presenter today. I am joined by Ashley from my team. Her job is to make sure that she monitors the chat. If there's questions she can answer, she might give you an answer back in chat. If not, she might ask me questions later. She's going to look for anything going on. She might give you a few resources. So just remember that that's what she's doing down there. Uh, if you are at the end of this presentation slide deck, please remember to review the disclaimer. Lots of information going on there. I want to remind everyone that we will use CPT codes throughout the presentation and CPT modifiers. So you may want to be just aware that, they are not owned by us. They are owned by the American Medical Association, and there's a disclaimer to go with that. So what are we doing today, and why is this so important? Well, first, what we're going to do is look at evaluation and management services and try to determine if they're separately payable during a global package. That means that the documentation must support a separate payment, and that's what we're going to talk about. I will tell you we had some pretty basic questions come in on global surgery and the concept itself. So we built a section for that to make sure that people are aware of what global surgery is. Then we do want to look at when we can separate an E&M, and then what is the appropriate modifier to indicate to the Medicare processing system that you would like to separate that E&M from the global surgery package. Again, I would really encourage you to use that chat feature should you have a question that you want to include. So the first thing I'd like to talk about is just what is the global surgery package and what does the global surgery days mean? This is a higher level overview. We did do a webinar a few weeks ago just on the basics of global surgery. It went more in depth. So you might want to take a look at that. And if you're interested in more about the global surgery, again, this is just a high level to kind of hopefully answer the questions that you have. All right, so what is the global surgery package? Um, this is a single fee based on the surgical code. And there are certain things that are included within that single fee. That's what the relative value units, which create the dollar amount in the CMS files, do work together to create. So CMS then says, okay, that single fee has components. The components are pre, intra, and post-operative for a surgical code. So what component are you doing? And then you have to also indicate whether or not an evaluation and management is separate from that. One thing that is applicable here is one provider. So that means it's the same provider performing all services. It's not necessarily all providers, but at the same time, remember that that one provider is responsible for the entire global surgery package, which is why they're getting the single fee. Now that does allow for some follow-up stuff and things like that. Again, as you said, it's post-operative care, and we'll talk more about that. But you do have to modify us should that not be the provider that's doing the post-operative care, which means put a modifier in the claim to indicate that. We'll talk more about that. Someone asked if this is a surgical bundling package. Sure, if that's the term you want to use, but I do want to let you know that it is not about like the National Correct Coding Initiative, which is the components of a surgery. Instead, this one says, in order to do this surgery, here's what you have to do. Unlike during the actual surgical procedure where you have to do the following things to complete the surgery. This one then gives pre and post-operative work as well as the surgical. So yes, you could call it a form of bundling, but I don't want you to get this confused with something like the National Correct Coding Initiative. Hopefully that does make sense again. If not, please put some more information. Okay. Let's summarize all that great stuff. The purpose of the global surgery concept is to allow a payment for surgical procedures. That payment then incorporates pre-operative work, intraoperative, and post-operative work. It applies to surgical procedures, which then incorporates some information on evaluation and management services, and we'll talk more about when it can be separately. Okay. If that evaluation and management is routinely done as part of the surgery, then it should be incorporated within it. Medicare does use the term physician or one provider to represent the entire package. Okay, so we'll talk more about that. Please remember this is under the Medicare physician fee schedule. It's not under the ambulatory surgery fee schedule because that's for a facility. So we'll talk a little bit more about some of these different things. All right. Underneath here, one of the concepts that first comes up is, does it have to meet medical necessity? This was something that was asked. This has not changed in years, but it does still have to meet medical necessity. Based on the Social Security Act, Medicare can only pay for services that are medically necessary. And that's in section 1862A1. Well, why is that brought up when we talk about this? Because we can't pay for outside interventions or outside reviews for certain services. So if the patient doesn't have an underlying condition and the surgeon says, well, our policy is just to simply go out and have them do a primary care service or a primary care visit, and the only thing that primary care is doing is saying yes or no, they're cleared for surgery. Why couldn't the surgeon have done that? They're both medically trained doctors or doctors of osteopathy, right? So they should both be able to do that. So that's where we come in with medically necessary, and that's why the package exists. So we do look at the decision for surgery. Now keep in mind, this is different than when the decision for surgery is because they came in saying, I have a stomach ache today, but then we find out they need an appendectomy. Okay, yep, we're going to do the surgery right now. Otherwise, we're going to have this other issue. It's two different things, more than just a pre-surgical visit. There's also the actual portion that goes with the surgery. This is always payable to the surgeon, and you do have to be qualified. You can't just say, hey, I did this service, and we're like, wait, stop. You're not qualified. You're not qualified through the Medicare enrollment process. We want to make sure you're doing that. When we look at the intraoperative section, though, we also then look at what needs to be done as part of that procedure. That's where you're going to find the national coding initiatives to say this procedure code incorporates all of these other elements, which are your minor elements. But on top of that, with the global surgery concept, oh, now we've got pre and post work assigned. Hopefully all of that makes sense. The last part is the postoperative period. And this is what normally happens after a surgery occurs. The postoperative period starts the day after the surgery. That's why sometimes you'll hear us say there's no postoperative period or 000. It doesn't mean that they don't normally go into recovery or they don't normally do those things. That's all part of what you need to do to this surgery, but it should all be done on the day of surgery. Okay. On the other hand, maybe you put sutures in and within the next 10 days, they'll need to be removed. That may be part of the postoperative period. So the postoperative period, and we'll talk more about that. Now remember, pain management is part of the postoperative period. Part of the question that we did get in is whether or not a medication check or a medication in general is separately payable. I can't answer that because what you're not telling me is what is that medication used for? Is it a pain management medication? Or is it, hey, they've got to do their A1C or their diabetic medication, which is not related to the surgery. So without a little bit more information, it makes it very hard to do some of that stuff. All right. So then there's also some miscellaneous services, and we'll talk more about some of these different components as we go through here. And we just want to get those definitions out of the way first. So first, I do want to remind everybody, one of the biggest definitions on slide 6 is one provider. What Medicare uses to define one provider for the general concept that goes with the global surgery and the E&M is that they have to be in the same group and the same specialty. Okay, that means that this is one provider. Now, the global surgery package does incorporate services from other providers. So should the surgeon or the one provider be able to do follow-up, track that surgeon for 10 or 90 days, or I'm sorry, track that patient, not the surgeon, track the patient for 10 or 90 days? And the answer is yes, we expect that to be done. That's a little bit different than one provider. Now, somebody did submit a question that in their group, the actual surgeon who shares a specialty with another surgeon, but the second surgeon, physically a different person, does the follow up from the first one. That's fine, but they're still billed and paid as one provider so long as the tax ID is the same. And I'm not really sure exactly how your group is set up. Um, so I don't have the best answer, but that's really what I can give you at this point. So if you have more information, it's probably a good idea to throw that in chat. We'll talk about in a little while. Okay. So that's how Medicare uses this particular information. Now, can a surgery be applicable for the physician and the surgeon? Yes, it can happen in a variety of settings. Ambulatory surgery centers, hospital inpatient and outpatient, intensive care, critical care units, and a physician's office. These are some settings that could happen in. But remember, it's not about necessarily the facility payment. That's a separate set of information and a separate set of payments. So that's why we have to use a correct place of service to reflect this accurately. But that's not anything to do with the global package or anything like that. So we want to make sure that the place of service is correct. The question, I guess I should have put the question in there for that. Does the place of service that it happens actually affect the payment? And the answer is yes, but not for the global surgery comment. Remember, if it happens, and we'll use this in an outpatient hospital, and that on the physician fee schedule shows that there's a facility and a non-facility rate based in who's paying the overhead for that facility. That's the type of effect it has, not necessarily about the global concept. So hopefully that answers that question. We were asked about the days, and I think that this is where some of the confusion came in. Let me first quid pro quo this too. This person said that they are new to global surgery billing, the professional side. So my response is they probably have billed for a facility side, whether it's an ambulatory surgery center or a hospital. So if that's not the case, again, make sure that information gets put into chat. But let's just talk about the days and what this means. So CMS, sorry, I have to grab a drink here. Hold on one second. All right, apologize for that, but my voice is like getting a little shaky. So CMS does use a chart on their website. Now the chart's in the form of an Excel file. And on that Excel file, which is named the relative value units, it has a lot of information, everything from components like to how much the fee schedule is and what are the different items that make up the fee schedule for procedure codes paid underneath the physician fee schedule. That's what we're talking about with global surgery concepts. And then they go on further, and there's a column down the way that talks about the global surgery concepts and even some of the modifiers that can be used with it. But the global surgery concept uses a variety of indicators. The most prominent indicators you will see are 3 zeros, and this equals 1 day for a surgical period. Well, that means that there is no preoperative day. The preoperative work should be done on the day of the procedure. Then there's the day of the procedure, and the postoperative work should also be done on the day of the procedure. Now, I didn't say surgery, I said procedure because like a colonoscopy could have this. You know, there's certain things that are going to fall into this. But what CMS is really saying is it's all about the day of the procedure. The reason that it says 000 is it's referencing postoperative work that starts the day after the procedure. Well, in this case, there isn't any. We're going to take a look at these files in just a little bit, so bear with me as we get through some of these base definitions. Now, there's also 010, which really equals 11 days. So that's the day of the procedure plus 10 days following. That's an 11-day concept. So the day of surgery and 11 days following. These are both considered by CMS to be minor procedures. CMS does have a 90-day global period, which is actually considered to be a major surgery by CMS. And this one is a little bit different in that it has the day before, the day of surgery, plus 90 days following. So the major procedures actually incorporate 92 days. Okay. So just a lot going back and forth with that. Oh, I do see a typo here. I said 10 calendar days following. On the slide it says 10 calendar days following. That should be 90 days following. So we want to make sure that we're well aware of how many days are going into this. You will see a link down on the bottom, and I'm going to use this just because I want to show people we've actually had some questions if people are not familiar with them. If I select the link, what it will do is automatically open the web page for that. And I am hoping that, there we go. So when it opens up, it'll just bring you out to the Medicare physician fee schedule relative value units file. The lookup will give you a much shorter version, but the full file is down here. You can see there's a little dark blue line with black writing versus the blue, the light gray and blue. So this is what we're on. And then it's broken up by quarter per year. So A, B, C, D, which is 2025, or 2026, which only has A because that's the only quarter we're in. This is on the chart in the body. I'm just going to go ahead and drop into the chart. The reason that I think this is important is to show you that it has all the information, but it also has a date right here. And this is the date that it began. You can read the full description down here. Okay. This will be a zip file. So you're going to go ahead and select it. And the zip file then opens up. Let's just put this on my desktop right quick. The zip file will open up and it will show you what you need. Now keep in mind there's going to be more than one file inside here. So let's go ahead and open that up. And this is what that's going to look like. Now this was a question that we got in, and I'll go through this as we get a little bit further in. But the file that we're actually going to look at is down here. The description of that file is here. And could you use a different tool? Absolutely. This is a lookup of that file. So this is just stepping back, and actually before you download the main file, you can look up just information. We'll get more into that. We'll get more into the file in just a few moments. Okay. So that's the days you're looking for, 000, 010, or 090, and the number of days that actually apply to that. Someone did ask about some of the other items that apply, and you will see a YYY. This type of code is actually contractor priced, therefore it doesn't have like 00010 or 090, because as we review the medical records to determine how much you're going to get paid for it, we also have to establish whether or not there will be global days to go with it. So that's all the YYY means. It could be any of those three, but the contractor will do that for you. Then you see ZZZ. This is an add-on code. So when you go to CPT, it's going to tell you, hey, this is an add-on code. You got to bill it with this. The global days actually apply to the main procedure code, not to an add-on code, which is sometimes confusing for people, but it does apply to the overall payment base, if that makes sense. But you got to build the primary code in order to build the add-on code. And last, you'll just see an XXX, which simply means not a global surgery concept. In other words, this type of payment, the intra, pre, and post, it's not there. That happens when it's not even a related service to a global surgery. So let's just talk evaluation and management. You go in, you do the evaluation and management. That's not related to like a surgical procedure where you're checking things at the beginning and after. It's not like that. The evaluation and management itself has its own separate codes. So hopefully that makes a little bit of sense. And I just, if you're wondering more about these, let me just show you what we're going to look at with those. Again, as I said, they're all going to be within this bottom file. And this bottom file is a PDF document. I'm trying to open it because it did decide, there we go. And you'll can read through all of the different information. This has decided that it's giving me a message. There we go. Um, so here's the pricing, but if we go down, you're gonna see it flip. You're gonna see it from flip into landscape view, which is right here. The next page, again, these are not page numbered, which is why I don't say page number 3 or 27 or 64. They're just not page numbered. So you're just gonna have to scroll through. Now, if you know are familiar with these, yes, you can get through what you need to get through. Um, so you're going to come down through and you're going to look after all of the I'm sorry, RVU files, you will see this global surgery indicator. Okay, and then it explains exactly what I just went through. So here's the 0, the 10, the 90, all of that different stuff. So it is here for you. You don't want to take notes and you want to open this up, awesome. Please feel free to do so. That's again in the PDF document. Well, what are these in particular? These are where you're going to look to find out whether or not they're on a certain column, and these are going to be your columns. So A, B, C, D within an Excel file, and the Excel file is directly above it. Okay, so we'll just again take a quick look at that as we get into this, because the next section is we're going to talk about the separate evaluation and management, which is a little bit different than this portion of the general surgical overview. So you can see HCPCS code, jump back to this, and we go back up to the very first one. Okay, modifier description, again, translating across the board. What we're looking for is this one, which is the column that we're going to use, or we're going to talk about whether or not it applies. So here's your, ZZZs, your YYYs as your X's, 10s, and 90s. Here's where that C comes in and says, hey, the carrier has to price it. I'm just going to open this up to make it a bit further, give you an example. Here's an example of something that would look just with the 90s, that would really be those 92 days, okay? So we could have multiple procedures. It's also bilateral. So there's lots of surgical information on here, but in particular, your global surgical concept days are here, right? Jumping back to this. Let's talk, can we separate an evaluation and management? What makes this separate? What makes this something completely different? And the concept says all surgeries have a portion of an E&M involved with it. It is typically a lower level portion. That portion is usually done either the day before, again for a 90-day, or the day of. So how many of you have ever gone in for surgery and the surgeon, whether it's their nurse or the surgeon themselves, maybe a PA comes in and they really ask how you feeling, you got any issues today, you ready for this? Those are part of that evaluation and management. What they're making sure is that you're not sick, that your body can handle that surgery. Those are just normal parts of it. Now you may or may not have had a different type of service before where they're saying, hey, what medical conditions do we need to consider, or whether or not you need to go see a separate specialist or primary care because of those medical conditions, and then you get cleared in that manner. That's different than just the base E&M, which basically says, how you feeling today? What's going on with your body today? Okay. So those are some things, remember, that are separate, right? That evaluation, that decision to make that surgery, that is separate from the surgical package. Even if it's done on the same day, in most cases, it is going to be separate, okay? Somebody asked about unrelated services or unrelated evaluation and management, and yes, those will be separate, even for an underlying condition. So for example, the patient goes into surgery to repair a fracture on their leg. This does have a 90-day postoperative period. The patient develops tendonitis or a rotator cuff issue. The patient returns to the same doctor, orthopedic doctor, to evaluate the shoulder pain and other things going on with the tendonitis. Now, keep in mind, it was a leg fracture, right? Now we've got something else going on with a different portion of their body. This office visit is completely unrelated to the leg fracture, which is why you could append a modifier 24 to indicate to Medicare that this needs to be separately payable even though it's still within that postoperative period. So hopefully that's just one example, and hopefully it makes a little bit of sense. Okay, let's go ahead and move on to a little bit more information. Sometimes we will hear the term additional excluded services. And what does that mean? When we talk about E&M, it's the complications returning to the ER that we didn't know about. So it's not a scheduled return, and there are different things you can do with that, and we'll talk more about those. And that could be a modifier 78 as an example, but we'll get more into that. Additional services, there might be a time when you have to look at using more than one evaluation and management modifier, and it really just depends on what's documented. So we'll talk about those. All right. So let's talk a little bit about some of the documentation. Now we start with the documentation because this is where some of the key failures occur. If it's not properly documented, you should not be billing a modifier to Medicare. If it's not documented, it didn't happen in the Medicare world, doesn't mean that they didn't physically do it. I didn't say that. I said it didn't happen in the Medicare world because the documentation is what must support it. What must it support? Two things. One, that it was medically necessary and that it was separate. Whether it's separate because of a different anatomical site, whether it's separate for a variety of different reasons. So yes, it's medically necessary, and two, that it's separate. If you're asking yourself base questions, those should be what you're looking for. Okay? When we talk about a decision for surgery, I gave you the appendectomy, and that's absolutely a great example. The patient comes into the ER, they don't feel well. The ER physician does a variety of things and then says, "Ooh, let me call in this surgeon really to check and see what they're thinking." The surgeon comes in and says, "Oh, yeah, we got to get him into surgery right now and get this out." That decision was made that day. You could not have known in advance. Like, you didn't know the patient was coming in, therefore that would be a separate decision. Okay. Now you should have documentation to support, one, that they came into the ER, two, that this physician in the ER did whatever they did, which is what led to them calling in the surgeon. The surgeon then documents what they did, which is what makes it a separate E&M from the surgical procedure. So hopefully all of that trails together, but each portion must be documented, and that documentation must stand alone. Also, one thing that has come up with documentation is, it's all entered into one particular note. And there's no way for us to differentiate inside that note who did what. That becomes problematic because these are separate specialties, right? The ER physician typically is not automatically a surgeon. The surgical physician is typically not working just alone in the ER. Yes, they're in the OR, but not necessarily in the ER. So if we can't figure out who did what, that becomes problematic. So when you're reading through the documentation, see if you can identify that. If not, you might need to help. You might need to add an addendum or something to kind of say, okay, this is what happened here. This is what happened here. That way your system is really showing us who did what and why this should be a separately payable. Okay. We should look at the documentation, and we should support the use of a modifier. If it doesn't support the use of a modifier, even we had one question come in that said we suspect that it should have supported the use of a modifier. I'm going to tell you that you might want to refer that back to either your surgeon or your original physician, whoever you want to do there. I'm not sure what the use was, and see, did they get everything documented correctly? Do they need to add an addendum to explain what information they missed? If not, that's okay. But as it would stand, if you don't feel like it supports it, you should not bill with that. Would not be a separate identification of a evaluation and management code. Okay. All right. So a little bit more moving on here is the modifier usage. Um, One of the things that has come up is that we're reporting something like a modifier 25, which is an evaluation and management modifier, but we're reporting it on a surgical code. Well, the two don't play nice in our system. So make sure that one of the biggest errors we see, again, once you leave the documentation, is that you're reporting it on the correct code. We'll talk more about that. Make sure that we are not reporting for the same group and same specialty. Non-physician practitioners, which include your qualified healthcare professionals, they are still going to fall within that, though some of the decisions they make may be separate. And again, it is really dependent upon what's going on with that surgical code and why the referral happened there. When you put it on the claim, where does it go? Well, very simply, if you're billing a 1500 claim form, it's item 24D. Same thing. Now with item 24D, there are some that are considered informational and there are some that are considered pricing. Our system, the way that we have it set up, always wants a pricing indicator versus an informational indicator. And you're like, wait, I don't really know which one is which. We do have a couple sets of information out here to help you determine which one should go first. Now out here on our website. So you're going to go to WPSGHA.com, which you can see I just flipped over to. From there, you're going to go to the topic center. If you say I want to do this, you can search whatever you want to do, and that'll be that'll give you the information as well. But the long navigation way is to go to the topic center, go to claims, and then scroll down, and you're going to look for the word modifier. Now I know it says there's one item, and if you open it up, yep, there is one, but this is a landing page, and the landing page has a variety of other items, and notice the first one is informational only. If we flip to part B, which is where the global surgery package is, then you'll see pricing, informational, and an introduction. Okay. One question came in and they're a little confused because they feel like they're part B, but the information seems to not apply to them and is causing other RTPs. So what that tells me is that you are doing business on a Part A line of business, which is simply, are you billing on a UB04 or are you billing on an 837I? Then according to our website, the line of business is Part A. If you're billing on a 1500 or an 837P, then our line of business is Part B. So Part A and Part B are not benefit categories, and I think that was just a little bit confusing for a couple of people there. So when we look at these different informations on the claims, the results are that you will bypass an edit. This does allow faster processing and perhaps an increased payment if you bypass that edit. Okay? But an improper use can also cause rejections, meaning they're not compatible, or it can also cause denials. Now, denial may say, hey, we don't know what this is, or this is not represented. So we know that we must place them in certain orders. We know that the proper use says this is what we want. This is our basic system information. If you have questions and you're looking for informational modifiers, I will tell you that not many of the global surgery really fit into that. They really are designed to be more of a pricing modifier. And remember that some of the pricing modifiers say I did this or this, but not this, or I did this full service or I did extra work. That's what we're going to go through next. So then we do want to move into the modifier sections that go with it next. And that's where we're going to run through the modifiers. Before I do that, I just want to take a minute and ask Ashley if we had any questions so far on all the information I've given out.
Hi, Tom. We do have one question in the chat. And this question says, the NCCI language says the decision for minor surgery is included in the global period. Please clarify how WPS can have a different stance on that. And then they did include a quote from NCCI that says, if a procedure has a global period of 0 or 10 days, it is defined as a minor surgical procedure. In general, E&M services performed on the same date of service as a minor surgical procedure are included in the payment for the procedure, and the decision to perform a minor surgical procedure is included in the payment for the minor surgical procedure and shall not be reported separately as an E&M service.
Okay, so let's take that statement and go right back to where Ashley said, in general, E&M services performed by the same date of service. The key thing there is in general. It does not say absolutely under all circumstances and there are no exceptions. That's not what that says. It says in general. So we do utilize that in general. For the most part, yep, that decision is there. It's a minor procedure. You know, we're good with that. So when we look at it, we do have to look at, is there significant separately work? What's going on? What was the procedure? What was the information? What was the evaluation and management? Because the verbiage that you're giving me, that you're quoting, already tells you that it's not an absolute. It's not an absolute. So that means that that's why WPS takes the stance that we do. We have to determine whether in general is met. What does that mean? And that is based in documentation. So if you have more information, please let me know. But otherwise, I'm not really sure what you're asking me there. Ashley, anything else?
We did just have one more question come in, which is 90 global and a 10 global procedures completed at the same time. On the consult, would we use 25 and 57?
Okay, we're actually going to go through that as we get to these slides, but let me just kind of put it together. First, um, we don't recognize a consult in most cases, so Medicare doesn't use the term consult. It is a separate evaluation and management, and I want to make that as clear as possible. I don't want anyone to say, well, we coded this consult code based on Tom's answer. Nope, can't do that. If you do that, you're not going to meet a recognizable code for Medicare. Okay, that doesn't mean that you couldn't do an evaluation and management. Now, when we look at that, we do have to fall back into the global period, right? And yes, you could put a 25 and 57. It just depends. In most cases, however, it's not going to be required based on the information I'm about to give. So once we get through this section, if you still have some more, let's put some more questions back in. But I do want to kind of defer that off. Anything else, Ashley?
Nope, that was it.
Okay. So first modifier we're going to start with is 24. As I said, and what I did is actually put links out to the fact sheet. Um, Somebody did ask for me to define the modifiers on each modifier. So that's why this slide is built in. So the first thing you have to know is that it is an unrelated evaluation and management service by the same physician or qualified health practitioner, which is what a QAP is, during a postoperative period. So what makes this unrelated? Well, there are certain things that we're going to go through that will help you to define that. But keep in mind, this says same physician. That means that it's the surgical, okay? Surgical information. So unrelated E&M performed during a 10 or 90-day postoperative period. So this is 24 used correctly. Here's the codes that we're looking at. Here's some ophthalmology codes that could be used again, just depending on what you're looking for there. Remember, E&M is for treating the underlying condition. That would be a correct use. The underlying condition isn't necessarily included in the global surgery package, and we still need you to treat that, okay? The system does use a diagnosis code to determine whether it's related or unrelated. And that's why sometimes you have to give us this modifier to tell us, nope, it's not. It can be a situation that one of the questions that was asked is, could the diagnosis code be the same on the claim? And the answer is yes, but it could be in a different anatomical site, right? That diagnosis code can apply to more than one part of the body. So make sure that when you're looking at 24, there's different things like that that you also consider. What's the anatomical portion? What are we doing with that? Um, if we're looking at this, these are evaluation and management codes, not just codes in general. So we want to make sure that we're getting all of this information together. All right, incorrect uses. Um, we don't want you to say, oh, it's separate because it was an infection. Well, no, because that's still related to that. The infection is a cause of or consequence of. Now, there's different modifiers we can talk about in a little while. Someone asked us about a non-physician practitioner in the same group as the surgeon, and they're treating something that's not going to be unrelated. Okay, I understand they're a different specialty, but it could be like, could they go back to that surgeon, and just because this is a lesser paid or a lesser point of view, it doesn't mean that that non-physician practitioner is not going to fall under the same category there. Performing provider is a different group or specialty. Routine postoperative care exams. but it's exactly what it sounds like. You know that they're going to come in to do the following things. Maybe they're going to come in 4 days after. Maybe it's a 90-day global period. So we're going to have what we call the 5-day check or the 4-day check. We're going to have a 2-week check. These are your routine post-operative care exams. They're not separate because they're the routine exam that needs to be done. Surgeon admits a patient to a skilled nursing facility for a condition related to the surgery. So the surgeon is going to do an admission saying, okay, you had a hip replacement. It's got a 90-day global period, but we still need you to go get therapy done to make sure that that functions afterwards. And so they perform all of that information. That admission isn't separate. The admission itself is separate, but that referral to the admission is not. And then surgical procedures and labs, x-rays, all of those that are all supplied are part of that, are inappropriate to use it. There was a question related to 000 and when would you use modifier 24 on a 000. I'm not sure. uh, because remember, there's no post-operative period in terms of once they leave. So you should have everything under control when they leave that day. So if they're coming back in and it's got a 000, modifier 24 probably wouldn't be applicable because it didn't have a post-operative time frame other than the day of the surgery. So if they came back in the next day or more days later, it's not going to be a modifier situation for this particular modifier. So hopefully that does make sense. All right, modifier 25. This is the one that is appended to the wrong procedure most often, which means it's not appended to the E&M code. Instead, it's appended to the surgery or a different code. So please make sure that first and foremost, when you look at the modifier 25, you are appending to an E&M procedure code. And it's a significant, separately identifiable E&M by the same physician on the day of a procedure. Okay, now what makes it significant and separately identifiable? Well, someone just said, hey, for a minor procedure, this E&M's always going to be part of. Well, the key thing is CMS doesn't say always. CMS says in general. So that's where that quote came in and where I gave you the advice, because I wasn't talking about specific. That's where I also told you I need documentation to make that determination. Without that, I don't have a way of determining it. So modifier 25. Let's keep going with this a little bit. The provider provided or services symptoms or conditions may prompt the E&M service. Again, here we go. We know it's in the day of surgery, but what's going on with that? So they had something come in, they looked at it, they're looking at the services, they're looking at the symptoms, they're looking at the conditions, and it becomes related to a major procedure. This typically is always going to be separately payable. Now 10 and 90 days, it's a little bit harder, and it's really hard to get the documentation for this one, especially with a 99211, which is a low level evaluation and management. And you're saying, wait, on top of that, we also did a surgical procedure, and here's the 0 or the 10 days, not the 90. I misspoke. They're the 0 or the 10 days following. Our response to that is, what made it so significant and separately identifiable on that day, on that morning, on the day of that procedure, that it's separate, especially when you're doing such a low level E&M, even if this low level E&M is being done by a non-physician practitioner in the same group. So we do take a little bit of a look at that. Now, there are automated edits that would exclude certain things and that are reimbursement edits only. Again, however, those edits can be checked with documentation. So when we look at it, what are we looking for? Was it a decision for surgery? If it was, does it have a 0 or 10 day? Then we have to look at that further. It's not like you automatically say, yep, this is done. And the appendectomy is the one that I use. It's a 90-day global period on an appendectomy. So that decision for surgery would be separately payable because it was more intense. On the other hand, if it's a 0 or a 10 day, now we really do have to pull some probably documentation, see what's documented to see if it meets that outside the general category. So again, not common, but not impossible either. Okay? You can use this based on a diagnosis code alone. We do know that I'm sorry, you cannot use this just based on a diagnosis code. A diagnosis code alone does not make it separately payable. And that could be a pain diagnosis code or something like that. They came in complaining of something pain. Okay, well, then the diagnosis code goes on to further state, hey, we did a surgery for. That's why it's not necessarily separately payable. And I know that one's very high level. Uh, One of the biggest ones we've seen is that a lot of people have automated edits that automatically apply this based on certain condition codes or are based on certain conditions being met within the edit. And what we've really seen a lot of times is they're not sophisticated enough to catch everything. And so that this is then causing other issues. The other issues are overpayments. The other issues are takebacks. And there also are some of them that are actually causing denials. And the denials then have to be overridden through the appeals process or overridden through a corrected claims process. So it's just best not to do those automated unless you can. We did have a provider or a person who registered say that this is just automatically appended. I'm not sure if it's your system automatically appended or if it's something within your work instructions or if you're questioning whether that's done automatically through a compliance, but we never recommend automatically appending or having it done every single time. We really want you to look at the individual and evaluate whether an individual, especially with a 10 and the 0, because you really do have to evaluate whether it meets an exception to the norm. That's what it says in general. In general, you wouldn't do this. So why do you have an exception versus an automated um, or every time we just code it that way? That's our direction. Critical care during a surgical period, the critical care is separately billable. The codes are different, so we want to make sure you're aware of that. And there are certain things that can and cannot be done. Um, 99211, our system doesn't allow for that. It's like, oh, you're doing such a low level E&M and you're appending a modifier. Why is that not part of your global surgery package where you're actually just evaluating whether or not they're able to have surgery? So the system doesn't do that. And then do not append an EN code indicating new patient. It's automatically excluded, and those are the E&M codes for new patient. The reason for that is if you've never seen this person before, we assume that they are new to you, that you're making a decision separately from, oh, we're just walking in. So can you tell me in your group practice whether this is considered a new patient? Just to answer one question, yes, Medicare does define new patient. Yes, it is 3 years without having seen them within your group. And group is specialty driven. So it's not new patient necessarily to the practice on an entirety level. So maybe they do have a cardiologist with you, but what they're coming in for is an appendectomy, which is the one that we keep using. They could still be a new patient for the appendectomy, but not for the cardiology. Hopefully I explained that correctly. We want to make sure we do meet the new patient criteria. All right. Next, um, very, very easy when you look at this one, not easy to define, hard to do, I guess is what I'm trying to say here. We do need you to tell us why this is a significant amount of work above your standard evaluation and management that is part of your global period or part of your surgical evaluation. Can they do it today? I walk in, you talk to the patient, checking for fever, all of those kinds of things. You need to be able to identify what makes it separately identifiable. So we always suggest that you look at and you perform a self audit. Again, not on every claim, but just once in a while. You identify the incorrect use and you make any appropriate refunds. But if you're not using it enough, you identify that too, and you can adjust those claims or submit new claims to make that separately payable. So really, what's what you're looking for when you're talking about modifier 25? Oops, sorry. Next is modifier 57, and this indicates an E&M services resulted in an initial decision to perform the surgery. This is the day before a major surgery, so a 57 is appended. The day of a major surgery, it's not a critical care service, but it is the day of a major surgery, okay? Things to know about modifier 57. Appending 57 to a surgical code, again, it's defined as an E&M, and we do see this on occasion. Not as high as the 25, though, but it's still seen on occasion. An E&M procedure code performed the same day as a minor surgery does not get a 57. Now you said, could I append a 25 and a 57? My answer to you is, what are you doing that you need to append both? Why isn't a 57 or a 25 enough to define it? Now, I don't want to make it seem like you could never do it. I can tell you, no, we don't have a necessarily built-in edit. What we do have an edit is it may stop and ask for documentation. It may do a couple of additional things there. So the edit isn't written as an absolute denial. It's written to have us look a little bit more at the claim if you put the two together. So just kind of be aware of that. In most cases, though, you won't do that. Um, the other ones I feel like are pretty good on this slide. So for a pre-planned or pre-scheduled surgery, so this could include a pre-planned or pre-scheduled back. If the surgical procedure indicates performance in multiple sessions or stages, this is the description of it. So when you look at the description as written by AMA, if it indicates this is going to take 4 times to get this done because it is what this is, or that's a staged or multiple session. Okay. So let's move on. Modifier FT. This is our last modifier for this. And this is unrelated E&M visit during a postoperative period. The key thing here is unrelated. It doesn't mean the diagnosis code is different. It just means this E&M is not related to this surgical visit. Okay, so it's on the same day as a procedure or another E&M visit, not for Medicare. So someone said, is this Medicare? And the answer is no. Medicare doesn't recognize it on another E&M visit. We do look for it during the postoperative period. Okay. Correct use for critical care visits unrelated to the surgical procedure, but performed on the same day. Critical care visits have their own category. And is it on the same day? Well, yes. You can still do a critical care visit for something not related to that surgery. They could be in critical care for a variety of reasons, and they could need a surgery. Okay. When critical care services performed during a global period do not relate to the surgical procedure, and that's a key and important aspect. When critical care relates to the surgical procedure, then it isn't part of the correct use. So we do look at surgeon and other practitioners as it relates to the group practice. When critical care is not in the 10 or 90-day global surgery period, someone said we put FT on every critical care code. That is where the question came from, because I don't really know why you would need to do that if it's nothing related to a global surgery period. Could they be in critical care for a variety of other reasons? Yeah. So I'm not really sure why we needed to do that. All right. Just look at some documentation. One, are they critically ill or injured, or both? Is there an acute impairment of one or more vital organs? A probability of imminent or life-threatening deterioration? It does involve high-level complex decision-making. And again, unrelated to the surgical procedure. All right, could you use multiple modifiers? You can. So again, the decision for a postoperative period of another surgery. So you had a surgical, now you're going to do another one. You have 24 and 57. We will start a new postoperative period depending on the other surgery. Significant separately identifiable on the same day surgery with a postoperative period of another surgery. You may be able to append the 24 and 25. Now, again, I really need to look at the documentation. This is one of the things that they kept emphasizing when I was talking to my medical review and other people. They're like, wait, yes. So yeah, you could, but it really depends on what's documented. And I think they said it about 25 times to me. So unrelated critical care during a postoperative period of one surgery and the decision for another major surgery. Again, yes, you could put those two together. It just depends on the situation you have and what you have documented. All right, so before we go on, let's do just a couple of questions. I will answer a couple of pre-submitted questions, and then we'll go ahead and hit up anything that you have in the chat. So if a Here's the first pre-submitted question. If the provider sees a patient on day 1 for abdominal pain, but no surgery is mentioned, and sees them again on day 2 and decides that it's appendicitis and the surgery is that day, can we bill a 24 and day 2 on a 57? I'm never going to say no, you can't do this. What I am going to say is in most cases, that original one is something that's still considered to that global period, depending on the documentation and the support for it. Just because they didn't find out what actually happened on day 1 doesn't mean that it's separately for abdominal pain. Okay, so I'm not sure what tests were run. I'm not sure about any of that documentation. So I don't want to make it say never, but I also do need to put the quid pro quo into that, okay? Um, Question number 2. If the diagnosis code or problem involves the same location, however, is a complication due to the patient's non-compliance, is an E&M billable with a modifier? Medicare does not necessarily allow this, but I will tell you document this. Now, I said not necessarily because depending on what's documented, why the non-compliance happened, what the complication is, how many days are out, what's going on with that, it is definitely something we can consider. But the key thing there is consideration based on documentation. Somebody asked, are x-rays covered during a global period? And the answer is yes, they may be covered. X-rays definitely have a component that has nothing to do with the physician fee schedule, which is what the global would apply to, and that component would be the technical component. I'm not really sure what you're taking x-rays for, the purpose of that, but yes, they're covered. X-rays could also be covered to track a variety of different things. So I don't really know the full answer to that. I don't really have enough information. But yes, they could be covered. Keep saying could because I don't have enough. If a patient has a procedure, then returns within the global period for medication refill, does this constitute the modifier 24? I think I mentioned this one earlier. I'm not sure what the medication refill is, so I don't really know how to answer this. Let me give you an example. Is it related, such as the painkiller refill, and they need more painkillers? Or is it unrelated, such as diabetic? Well, that's an unrelated underlying could be an underlying condition, but it's not actually related. And so putting a modifier on there, we really have to look at whether it's related or unrelated and all of those different types of things. Somebody asked me how many modifiers are allowed on a claim. Typically 4 modifiers per line. However, if you were to put modifier 99 on a line, you can then list all the modifiers you want in the narrative segment. So if you have more than 4, that's where you need a 99 and you get to list them in the narrative segment. All right. Last question. What if the patient comes in for an unrelated procedure by the same physician and the physician performs a related procedure and an unrelated procedure that needs to be done? Yes, you can modify that. You can't be paid for the same full evaluation and management underneath both. But did you do a separate unrelated procedure? Yes. This is where some people like to call it carve out or decision to be made. I can't answer that because I don't have the information in front of me to really make that clear or separate. But yeah, we would consider that. We're going to jump back, and I know we're running over, but I want to make sure I get all these questions answered. Ashley, do we have anything in the chat?
We had a couple more questions come in. The first one is, if a patient comes in with stomach pain on Monday and surgery is not mentioned or recommended, but the next day more symptoms develop and surgery is recommended and performed, do we put a 24 on the day before, or is it included?
In that case, from what you're describing, let me just put it this way, from what you're describing, you would want to use a 24, but it's really driven based on that one, based on the documentation. Really, we have to look at and be able to define within that. So I don't want to give you a yes, you can always put a 24 on it. I really need you to drop back to that documentation. One, could the physician have even determined that they needed that surgery based on what happened the day before? Use that kind of as your determining factor when you're looking at what's documented. I hope that kind of helps a little bit there. But otherwise, let's go on to the next question.
All right, we have one more question. If a patient is seen in the clinic with known hemorrhoids and being seen in follow-up with no current issues, the provider performs an endoscopy during the session. Should the endoscopy and the E&M be billed with with a 25 modifier, or would you only bill the endoscopy?
Okay, so the endoscopy is done as a result of, right? So again, here's where we're going to stand back and we're going to kind of look at it. And we're going to look at what's documented, right? So you came in, first of all, how high was the level of E&M? Because if it's just a simple one, you said, oh, no, we're just going to do this, then probably not. You're not going to get a separate payment because it was all designed to be within that. If, on the other hand, you're coming in and, yes, that's your primary diagnosis, but it took you work to get there. Okay, yeah, we know they have hemorrhoids. Yes, we know that. But now we had to do a full-on exam. We had to do this. Oh, okay, I see why that could be reported. So I'm not really sure where you're going with it because I'm not really sure what's within the medical record. So that one's a little bit harder for me to actually answer. So I'll apologize that I don't have a direct answer for that, but I'm not going to say it's not possible. What I am going to say is how well is it documented, the significant and separately identifiable, the reason for it. So hopefully that makes sense. Any others? Questions?
We did have one more come in. This one asked, what is covered under post-op care, like infections or osteomyelitis if it's developed during the post-op? Is an E&M okay to be billed?
So can you tell me what the surgery was? No, infection typically is covered as part of postoperative unless you're doing a return to OR or unless you're doing things like that. So those are all part of it. Now, there are times when, again, due to return, it's going to make a separate identifiable service. Could be a separate, again, OR service, and therefore it starts the global period over. So there's a variety of things that happen with that. In terms of other items, many of them would be covered in the evaluation and management because it relates, would also be incorporated within that postoperative care. I'm going to go ahead and stop there. Ashley did indicate that was the last one that we had. So we're going to go ahead and stop there and we're going to go ahead and move on. So as a reminder, we've given you a lot of information very quickly here, but we would really encourage you to take our survey. There's going to be a link in the chat. Ashley's going to put it in there. I'm going to give you a box that looks like the one on the right side when we close out of here. And also, you'll be able to take this survey through the email that comes out. There'll be a link in there, but don't forget that even on an on-demand or an encore, you can take this survey by using the picture that looks like this at the very end. It's going to be usually within the last 20 seconds or so. And again, our encores are all posted to our YouTube channel. Incorporating this one into that is part of our goal. Thanks for attending. I just want to remind everyone that the questions and answers given during this can be affected by what you've actually documented. If you have further questions, please feel free to send those in. You have 7 days to do so. Make sure that you put global surgery and E&M modifiers or something similar to that. There are other global surgery education sessions that we have done, so you might want to check those out. They may help you out as well. When you send in a question, we're either going to email it back to you or email it out to the group, depending on the type of question. We do get some very specific questions. One thing I want to remind everybody is I can't look at your claim. So if you send me something, you say, based on my claim rejection, based on my claim denial, that must go through customer service. So thanks for listening. More to come on global surgery and some of the different modifiers and the other things going on that are not related to E&M. So check out our live events page and remember to register for those. On behalf of myself and Ashley and all who provide our outreach and education, thanks for participating. We look forward to your survey comments and hope you'll join us in the future. You may now disconnect.